I have the great pleasure of introducing Dr. Michael Yee. Mike, I was told about by several people as one of the most premier endocrine surgeons anywhere in the United States. His training is unbelievable. He's associate professor of surgery at UCLA. He completed his education at Stanford and Harvard Medical School, pursued surgical training at the University of San Francisco and at the Royal North Shore Hospital in Sydney, Australia, and he currently serves in the dual role of Chief of the Section of Endocrine Surgery and Director of Optimal Care at UCLA Health Systems. Under his leadership, UCLA Endocrine Surgery has developed into an internationally recognized center for world-class patient care, high-impact clinical research, and advanced surgical training. Dr. Leeds leads the effort at UCLA Health, streamlining high-quality patient care and reshaping the structure of healthcare. And, you know, he's gotten so many awards, it's probably not, and he's published hundreds of scientific papers. But to me, he's my personal surgeon. He took out my parathyroid adenoma a few years ago. I think it was about 4 or 5 years ago. And it's an interesting story because for years I'd been hypercalcemic, but thought I was asymptomatic, but my bone density was starting to go down. And I had expert radiologists and ultrasonographers and people look for the parathyroid adenoma I knew I must have, and they couldn't find it. And and so I went up to Michael and laid down on his table at the UCLA, and he took out his ultrasound machine, and in about 3 minutes he found my right parathyroid adenoma, pointed it out, saw the artery going into it, say, we pop that out and you're going to go well. And he did, and of course it went perfectly. He does about 6 parathyroid adenomas a day, something like that, 3 or 4 days a week. Is that right? And all kinds of other endocrine surgery, any kind of endocrine surgery you can imagine. He's an amazing speaker. Michael, come on up. So if you ever need anybody to do incredible endocrine surgery, this is the guy.
Thank you, Tom, for the kind introduction. I really appreciate it.
But
Yeah.
you have your,
Yes, I'm sort of double mic'd here. Good morning, everyone. Thank you for coming. I'm going to talk a little bit about endocrine surgery today, but only as a canvas upon which I'd like to talk about sort of more health policy and economics area. I'll start by confessing that when I met Tom and he told me about his practice model, I was a little skeptical. I was concerned that this was healthcare for the elite. We had lunch after his operation. He took a couple hours to recover, and his recovery, and then we just sat outside. He was fine, and then he told me a little story about how one of his patients was an older woman who fell down and had a shear injury of her arm, where a big flap of skin had come off. And then he told me about how he went to her home, and that he was able to flap that skin down to use as a biological dressing and use a few steri strips to allow it to heal. And that sort of changed my concept of what concierge medicine was. It made me realize that Tom was intimately familiar with this woman's history, that he was able to go to her home so that she didn't have to wait for 5 hours in an ER. He was able to do what was correct for her because of his experience. And it made me realize the tremendous value he brought to that patient. So that helped me sort of change my way of thinking about concierge medicine, and to realize, it sort of led to today, because I really think that there's a lot of alignment between what this association is doing and what our country needs. So I'll try to stay on time. I have a few key questions we're going to discuss. A little bit about endocrine surgery, just a little bit about economics and the root causes of our current problems, which boil down to a market failure of incentives. There's too much variation. There's asymmetrical information in our system. And I want to focus on this concept that's relatively new in healthcare, which is value. Right? What Tom was able to deliver to his long-standing patient, and what can we use as a model in endocrine surgery? Because we're very much pursuing the same aims. And so what are the lessons here? A little bit about endocrine surgery. We like to say it's for the thinking surgeon. And Harvey Cushing was one of the first endocrine surgeons in our country. And he said, I would like to see the day when somebody would be appointed surgeon somewhere who had no hands, for the operative part is the least part of the work. Indeed, in Tom's story, the operation was easy, was trivialized once you could find the target, right? So we deal with these main organ systems: thyroid, parathyroid, adrenal, endocrine, pancreas. And I'd like to impress upon you how powerful the endocrine system is. These are two patients with Cushing's syndrome. That's what she looked like before. Just a few nanograms of hormone. And as you guys know, Cushing's is a lethal disease. People die of metabolic syndrome, and it has a survivorship that is worse than most malignancies. We have patients that are women transformed into men because of a small amount of androgen. We have people that are short or tall if they have hyperparathyroidism, others who are cretins, intelligent versus unintelligent if they are hypothyroid, and others who really barely survived in the era before insulin. So our very identities, tall, short, fat, thin, men or women, are controlled by the endocrine system. And as endocrine surgeons, I'd like to think much more than technicians. We want to take care of the whole patient and restore their bodies to balance. You are all familiar with this graph showing that healthcare expenditure as a percentage of gross domestic product is much higher in our country than other developed nations, and we don't seem to get the value out of that dollar. It would be one thing if we spent that much and got real metrics to show that it was worth it, but we don't, because despite of how much we spend, our life expectancy is not as good, and with our core measures such as infant mortality, birth weight, that aren't as good in this country despite our expenditures. So why is that? How can we get a better value for our healthcare dollar? Well, again, I mentioned earlier that we have a market failure, and in a good market, in an efficient market, the price of a product actually reflects the value. That's how all of you selected your hotel room, your car, your washing machine, your massage therapist, all of these things. There's a defined price for a defined product. There's free and rapid flow of information. Sometimes you can use that on the internet. You get Yelp or Angie's List. My wife and I use Angie's List when we want a home repair. There's open competition, fair dealing. People act in good faith. We have courts to ensure that. And there are property rights. Nobody can sort of take away something you have arbitrarily. All these things are true in an efficient economy. But in healthcare, well, what is the product? We don't even know what the product is, all right? So my wife went in for a colonoscopy. Is that the product? Because that's what we're being billed for. I would say that's not the product. I would say the product is a healthy colon. What is the price? You go into the hospital, you get nickel and dimed for 5,000 different things, including Tylenol tablets. Unknown price when you walk into the hospital. You would never accept that at a restaurant. You would never accept that. We really have no transparency. Competition is so restricted, and this society probably knows that better than anybody else. In Los Angeles, the whole geography is cut up into tiny little insurance networks where people are captive. They can't go where they want to go. And competition is on the wrong level, meaning we tend to compete for global capitation. This many lives cost this much money. I think that is too unpredictable. You can't predict what's going to happen to this person over their lifetime. You can predict what might happen to them after cardiac surgery, right? So that could be, you could compete for a successful coronary revascularization and the rehabilitation. That would be something, a coherent cycle of care that you can compete over. And there are some institutions in the United States that are already competing on that level. What is value? Well, these are the things that patients care about. Doc, am I going to make it? Am I going to be handicapped, or am I going to have a full quality of life? How long am I going to be away from work and my family? How much is it going to suck? Is it going to hurt? Am I going to be throwing up? And am I going to be good for a long time? Right? This is a basic hierarchy of needs. Very, very simple stuff. Now, Anybody here a Atul Gawande fan, writing from the New Yorker? Atul Gawande, an endocrine surgeon, he wrote this beautiful article where the patient is sadly the ATM, sadly, called The Cost Conundrum in 2009. He referenced something called the Dartmouth Atlas of Healthcare. Anybody else familiar with the Dartmouth Atlas? So you can go and you can look up the Dartmouth Atlas, and it looks at regional variation in healthcare spending across the entire country. And those areas that are in red, we seem to spend a lot of money on healthcare, and those in white, not so much. Okay? But just look at the variation from less than $7,000 of Medicare dollars per person to greater than $9,000. That is huge. Okay, and this is part of a science called variation mining. If you start to find the variation, it allows you to ask the question, why is there variation? And is it appropriate or not? Okay, I'm going to talk to you about the extremes. The most expensive place for Medicare billing in the country is McAllen, Texas. Right down here is very close to Mexico. $13,000 average Medicare expenditure per capita per year. And Los Angeles, not so much better. But if you're lucky enough to live in Olmsted County, Minnesota, your costs are about half. So then let us ask, are people in McAllen, Texas, therefore twice as healthy as the people in Rochester, Minnesota? They should be, right? We're spending that much more if we're getting good value for our healthcare dollar. Absolutely not. The people in Minnesota are healthier. Now, different scenarios, right? Not too many people coming across the border in Rochester. It's a defined population, defined genetics. Most people are of Scandinavian ancestry. However, I don't think it can explain that much variability. So in this article, Atul Gawande went to McAllen, Texas to try to figure out what was up there. And people were not too pleased with his arrival. But it turns out that a lot of the long-term care facilities and other places where you could bill Medicare were partially owned by physicians. And so they were referring these patients to their own outpatient rehab and this and that, and really using the patient as an ATM. They were making more off of the facility fees for places they had a partial stake in the facility than actually taking care of these people. Okay? And so that just shows that most variability in healthcare does not add value. In medicine, we believe a lot in physician autonomy, and I'm all in favor of autonomy, but when you let doctors go on the wards in our hospital this morning and do whatever, make up the plan of the day in the morning, there's a lot of unnecessary stuff that goes in. Most of it does not help people at all. So we can reduce non-value-added variability through standardization of care based on best practice. We have a body of literature, let's use it. And that's something we did in endocrine surgery. If patients had high complexity care, we took care of them at our flagship hospital. At our flagship hospital, if you walk in and tell the OR, I would like to take off this person's head and put it on another person, they'll say, okay, when do you want to do it? And they'll provide you the equipment you need, and they'll get you some team members to help you, and you can do it. We also have an outpatient surgery center where Ton had his operation, which is just real clean and simple and efficient. And then we have an intermediate facility where if somebody has a technically straightforward operation, but they're 92 and have a pacer and have had 2 strokes, or the BMI is 50, we can do that operation in an intermediate setting. So we did that. We also instituted clinical pathways. This is just one of them for total thyroidectomy to preemptively manage any complications that might occur, such as bleeding. This one's to manage their calcium levels because we don't want people's calcium to fall too low. And essentially, instead of continually checking the calcium and responding to that, we came up with an evidence-based protocol by which we measured a PTH, and depending on what it was, we gave you this much amount of calcium or vitamin D, and everybody's sort of pre-programmed. And what that did was it greatly reduced the amount of work we did, it greatly reduced the variability, and it greatly improved our outcomes. And we started making our operations smaller. Our operations this is the process of miniaturization of a procedure. You can bring the operative time from 2 hours to 20 minutes. You can move from an endotracheal anesthetic to an LMA. You can do it even under local MAC. If you're smart about taking care of people's pain and nausea, we can start to put in preemptive analgesics, put in a cervical block before you even cause the pain, and that will reduce the total amount of need. So there are people who have major neck surgery who wake up, have not received any narcotic. They got a regional block and some Toradol. They wake up and they smile and they go home 4 hours later. And this is our transition showing that we started with a 23-hour length of stay. We had some variability, transition, and by the end of this period, we got almost everybody down to a 4-hour stay. The national average length of stay for this procedure is 2.5 days. We have about 2.5 hours. We reduced the amount of hypocalcemic complications by using that algorithm. What about resource use? Well, look at like how many labs people got before the pathways and after the pathways. There was a 73% reduction in laboratory utilization. Let's stop for a minute and think what that means. That means that before, people were getting stabbed in the arm multiple times a day, and there was no added value for any of that. I just showed you. We reduced the number of hypocalcemic complications, and we greatly reduced resource utilization. And more importantly, there was no difference in the readmission rate. So we weren't sacrificing anything. We just got leaner. What does this mean in terms of cost? Well, here at the tertiary care facility, we set that to 100, and the outpatient operations the cost profile is half. Half. So these people are getting better care for a lower price. And this just shows how we grew our volumes, and the inpatient cases are the green, the outpatient cases, the surgery center cases are the blue, and the intermediate cases are the navy, and more and more of these are less than 23 hours. So we were able to grow our practice, and we utilized the fact that UCLA is an economy of scale, all right? And we were paying a heavy price for using the main OR. We used to use the main operating room for everything, but we were paying a heavy price for the capability of managing complexity. Does that make any sense? Because in the main OR, we had the capability to do the head transplant, but why would we pay that price when we just wanted to do something very simple on somebody who was lean, on somebody who doesn't have coronary disease, on somebody who had excellent social supports? So if I send them home to a hotel that night in Westwood, they're going to do fine. They're going to do better. They'll be more comfortable, and they'll save money. This is just how we grew our practice geographically and how we became a global destination through doing some of these things. So does anybody know who Michael Porter is? Harvard Business School. Some of his ideas are in this talk. I went and flew out and took a class at Harvard Business School for a week and came back with some of these ideas. Porter talks about the virtuous circle in healthcare delivery, where as you get busier, you accumulate experience, you get more efficient, and then you get dedicated personnel and equipment and technology. Let me give you an example. So we had a little boy flew out from Guam a couple months ago. He had an inherited pheochromocytoma. He called us. We had a telemedicine appointment with him and his parents. And I said, well, I'd like you to come here because we have a core group of pheochromocytoma anesthesiologists. There are 3 of them. They do all of our cases. We have dedicated imaging facility for this rare tumor, which you've all heard about in medical school. About 1 in 2 million people has it. But because people come to UCLA here, it makes sense for us to train a core group of anesthesiologists, because that interaction between anesthesiologist and surgeon, I'm convinced, is where the rubber meets the road in terms of the quality of care. It's not just, I mean, you can do a technically great operation, the patient can die from anesthetic complication. You need to communicate with that anesthesiologist. And we have dedicated imaging. It would not make sense for us to invest those resources if we didn't have a critical mass of those patients. It just wouldn't make sense. So again, it's the economy of scale. It allows us to innovate faster, and then we get better results, and then you go around the circle again. All right, so one of the insights is that improving quality actually reduces cost. I think most obviously in surgery, because what is costly? Complications, so costly. So if you can reduce the complication rate, the cost will come down commensurate with that. And to do that, we focused on the value equation. We delivered the right care to the right patient in the right place, at the right time, at the right cost by choosing the setting. What about waste? Anybody read this article by Berwick in JAMA, looking at waste in healthcare, and he talks about layer upon layer of waste. Different categories, failures of care delivery, failures of coordination, overtreatment, big fat light blue band there, administrative complexity, pricing failures, and fraud. And could we, if we just chipped away at all these different wedges, could we get growth in national healthcare expenditures that matched our GDP growth? I mean, that would be a wonderful endpoint for our country. This issue, overtreatment of thyroid tumors. Well, I just got back from the American Thyroid Association meeting in Denver. That was the #1 topic, was overtreatment of thyroid nodules. And anybody familiar with this article from New England Journal looking at this man-made epidemic of thyroid cancer in South Korea? Some of you know about it. So the #1 reason a Korean patient, the highest population of Korean people in the world is in the Seoul metropolitan area, and the second is where? Southern California. Yeah, it's the second greatest concentration of Koreans. And for a while, I kept on seeing these Korean patients who'd flown back to Korea, gotten a full body executive physical scan thing that the government's, that's a fee for service, and then were being found to have tiny little thyroid nodules, which were biopsied and found to be tiny little thyroid cancers, and they'd come in for an operation. Well, if you look here, that sort of screening caused an explosion in the number of thyroid cancer diagnoses, but the thyroid cancer mortality is flat down here, okay? So what it means is all these people are having surgery, and what's the value? There's no value. And here are the different precincts in Korea, all these little dots, and it showed that the more you screen for thyroid cancer, the more you find thyroid cancer. But if you intervene, you are not improving human health, because thyroid cancer is very much like a little prostate cancer in a lot of people. A tiny little 2-millimeter prostate cancer that I'm going to have when I'm 70, and I'm going to keep my prostate, right? This just happens in young women. 2-millimeter microcarcinomas, which probably shouldn't even be called cancer at all, and probably should just be left alone. Overtreatment, and this paper just came out a few weeks ago in the New England Journal, and the first thing your eye will see here is these humps, right? Camel humps, and the dashed line is the expected incidence of thyroid cancer that is adjusted for age. They use some fancy statistics to show before screening, what is the age-adjusted incidence we would expect. And the more it becomes a camel with a big hump in the middle, the more we are just picking up what we call overdiagnosed thyroid nodules on screening. Look at South Korea. I mean, wow, right? Mount Everest. United States, a fair amount. Italy, a fair amount too. So a lot of these small thyroid cancers, and it's hard to talk patients into this, all right? You have a small cancer, they hear the C word and they freak out. But a lot of these 2-millimeter cancers, I tell them, are precancerous. We should leave them alone. We should just refuse to biopsy them at that size, right? And we should definitely not run around screening people, because that's just non-value added. This showed up, whenever the New York Times gets a hold of something, it's a big deal, right? So this is just a different version of that same graph showing that in South Korea, 90% of these small tumors were overdiagnosed. Thyroid all over the New York Times this year, right? There was a certain type of, something that was previously called a cancer that now we agree behaves as a benign lesion. So again, if you use the C word, you're going to scare people, and we changed the terminology for a certain type of thyroid tumor. All right, so waste is a serious problem in healthcare. Sometimes I think there's some data to show that half of the care we deliver is wasteful. So we should eliminate waste by not doing this crazy stuff. And thyroid nodules are the perfect model for this, because by the time we get to my age, around 45, half the adult population has a thyroid nodule. 95 to 97% of these are benign, and they should be left alone. So overtreatment, I think, is almost as big a problem with thyroid nodules as undertreatment. Sometimes we undertreat them too. But the solutions are to know what not to biopsy. And I will tell you that this, I think, is the greatest value that I add to my patients' lives. They come in, they've got a thyroid nodule, I look at it with ultrasound, I'm like, that's benign, based on the ultrasound. We should not biopsy this. I'll see you again next year, right? If you can confidently call something benign using an inexpensive, non-invasive test, you're helping people. Am I going to be wrong some of the time? Yes, I'm going to be wrong some of the time. And so those people do need still a little bit of follow-up. But the burden of care, think about the other way. Think about if I told everybody with a thyroid nodule that they needed to have it biopsied. Some of them would come back inadequate. Some of them would be uncertain or suspicious. We would be layer upon layer of testing. Some of them would have unnecessary surgery, and the amount of complexity just snowballs, right? But if you can reassure, so even in our surgery clinic, the number one value I give to patients is by giving them reassurance. Reassurance, number one. So I want to try to stay on time. So sometimes less care means better health. And the trouble with this, and again, this aligns with the concierge model, is there's no CPT code for better health, right? There's a CPT code for colonoscopy, there's a CPT code for polypectomy, there's a CPT code for FNA of the thyroid, and so we make money providing care, but providing care is not the product. So we get paid for providing care. What we get, not surprisingly, is a lot of care, half of which is unnecessary. We really should be paid for delivering better health. All right, so can we link payment to delivery, the delivery of outcome, not the provision of care? Before I talk about the Brill article, I want to mention to you that I went to the CEO of the health system and said, I want to institute a molecular profiling system that for everybody who we do decide to biopsy, if it's an indeterminate nodule, I want to send all of those automatically for molecular testing so that in about half of those cases, we can exclude cancer with 95% confidence. And what that's going to do, it's going to reduce the amount of potentially avoidable thyroid surgery by 60%. That was what I pitched to the CEO. And he was like, okay, so you're asking me to invest $1 million so you can do less surgery? It sounded strange, right? And it was not a great sort of fiscal proposition for him, right? Not only was he going to invest $1 million, he was going to lose all that potential income from the operations we were going to do, and it was a bit of a hard sell. But I asked him, well, what would you want? Let's say it was your neck. What would you want? You know, and he said, okay, I'd want that. I'd want to avoid surgery if I could, and avoid the potential hypothyroidism, avoid the potential complications and TSH monitoring, and so we did it. And it immediately dropped the number of diagnostic thyroid lobectomies we did by 60%. So I'll ask the audience, what do you think happened with our overall surgical outcomes when we rolled out this program? Our overall surgical volume, the number of people coming to UCLA for surgery, did it go up, go down, or stay the same? It went up. You saw it earlier. It went up dramatically, even though we were doing less surgery on average per patient. And it's because a lot of people in Southern California said, oh, well, if I come to be part of the system, they're really going to try to help me avoid surgery if I can avoid it. And so the number of people coming in the door just doubled, which goes to show that if you provide people the service that you would want, word gets out. And paradoxically, it has, you do better financially. And we're also trying to convince people with small thyroid cancers, the Korean type ones, to just leave it alone, particularly if they're older. Particularly if they have significant comorbidities, those people, most of them are not going to die from thyroid cancer. They're going to die from something else. So if they have another cancer, if they have significant coronary disease, if they've got a history of multiple PEs and are on a blood thinner, let's just leave it alone. Let's watch it. Let's see in 6 months, see if this thing progresses. Maybe it won't progress, and then you'll be able to avoid that surgery. So all these things we're doing to try to eliminate waste. Now, some of you are probably familiar with this article by Brill called Bitter Pill, looking at medical bills. This is a lady who went to the ER and had a $9,500 bill for a few hours of an ER visit. This is a guy who went to MD Anderson. MD Anderson was kind of the bad guy in this article for overcharging people. A little bit of diagnosis and chemotherapy for non-Hodgkin's lymphoma, $84,000. I mean, these absurd prices. And if you look at their bills, this is what they look like. A chest x-ray for $333, a vitamin for $24, a gauze pad for $77, and a single Tylenol tablet for $1.50. And it says here you can buy 100 tablets on Amazon for the same price. It's nuts. So this was something that really was disturbing to me when I learned about it, which is that healthcare charges bear a mysteriously little relationship to the actual costs or value of what we're delivering. And I think the solution is transparent pricing and bundled payment. Okay? So remember, we talked about before that we're competing on the wrong level, we're nickel and diming people for all these things, but if you were to go out and shop for healthcare on Angie's List or on Yelp, you wouldn't be shopping for these nickel and dimes. You would be shopping for, get me better from my bad knee. How much does it cost to take my knee that doesn't work and make it so I can walk again? That's what we would call a cycle of care. It would be the knee replacement and everything, all the pain medicine and whatever, it would be all wrapped up together, and it would include the rehab, and if you had a complication, I think I'm going to go so far as to say the hospital should eat the cost of that complication. If you had a DVT or a skin breakdown or an instrument was left, hospitals are charging for that. It's absurd. Okay? Hospitals should just eat that cost and say, this is the price to get you better from a bad knee. And if all the centers in the United States would compete for that, we would really see some movement. And that's starting to happen. Okay? Cleveland Clinic has a price to get you better from your coronary disease. So does Johns Hopkins. Cleveland Clinic struck a big deal with Lowe's Hardware. You guys familiar with this deal? Lowe's Hardware. So if you're an employee of Lowe's Hardware, no matter where you are in the country, if you've got coronary disease, they will fly you and your family to Cleveland. They will put your family up in a hotel. They will do your coronary bypass, get you rehabilitated for some fixed amount of money. Let's imagine this is $35,000. So right now, there are people who are employees of Lowe's Hardware living here in Las Vegas who are getting on a plane and going to fly to Cleveland because that's cheaper. That is cheaper than going to the local hospital and having a complication and having a bill for $80,000. That's cheaper. And if Lowe's Hardware has figured it out, I'm sure they're right. They're smart businessmen and women. All right, so bundled payment, this is what happens if you want your knee replaced in Stockholm, okay? Here's the bundle, all your pre-op, all your labs, all your x-rays, all your surgery, the prosthetic, which is a huge chunk of the price, all your drugs, all your rehab, all your follow-up, and if you get an infection, they take care of it and is guaranteed up to 5 years. All that, 8,000 bucks, 8,000, it was priced in euros, but it's 8,000 US dollars, right? That's a great value. And then all the centers around Stockholm can say, oh, I can do it for $7,800. But in order to do that, they would have to make sure their complication rate is really low, right? So now they start getting creative. Now they start getting incentivized. Now they maybe let that one surgeon who had too high, maybe that guy will have to practice at a different hospital if his complication rate was too high, right? Now quality is getting better. Now the consumer is winning. So I approached our leadership at UCLA and said, we need to have a bundle price for endocrine surgery. And they said, you're crazy. Because what if you get a complication and the patient needs a tracheostomy and then needs to go to the ICU, and then if we say that the bundle price is this amount and we get into that loss cycle, then we'll be out $1 million before you know it. And I said, okay, I'll talk to you next year. And we did 1 year's worth of cases. We did about 700 cases, and I came back and I said, last time I was in your office, you were worried about all these complications. I would like you to audit all of my cases and let me know how many times that happened. 0. I said, okay, offer me a bundled price. Offer my patients a bundled price for thyroid and parathyroid surgery. And they came up with this crazy number because they were still afraid that it would be a complication. I was like, no, I'll do it for half. What are you providing? What's in your normal saline? You're given one dose of Toradol, a little bit of anesthesia, a little bit of OR time, and some IV fluids. What are you charging? Why does that cost $9,000? And then we shook hands on $6,000. Okay? And then there were some anesthesiologist fee, pathology fee, surgical fee, etc. And so you can go to the UCLA website, and we developed this for people who are out of network. Because if you're a Kaiser patient, and you want to come to UCLA for surgery, they just leave you to hang out to dry, and then UCLA perceives that you're a Saudi oil sheikh with a suitcase full of cash, and they charge you 5 times what they charge Medicare. So I was like, that's ridiculous. And who's winning that one anyway? I'm worried about time. Who's winning that one anyway? Because the patient won't come. They can't afford it. But if you were to charge a reasonable price at UCLA, you'd still make money, right? And the patient goes to inside their preferred provider network and has a failed parathyroidectomy, and they've got to pay twice. Anyway, so that's lose. Just lower the barrier so a school teacher, a policeman, or just a regular person in LA can come here and you get a bundled price for a guaranteed outcome. And so we did this, and it's still too much money. I mean, it's still $11,573. I just pulled this off the UCLA bundle pricing. When we started the bundle pricing website, the human body figure here had a single dot right there because none of the other surgeons were willing to do it. Had just one dot, like right over your neck. But I think that's still too much money, if you ask me. I would like that to be even lower, but this is the best I could do. And then there are now people who come, from Kaiser who can access this. And there was one guy who came for his thyroid cancer operation, and I did not do a perfect job. There was a lymph node that in an unusual location, and it showed up 6 months later, and he said, well, Dr. Ye, I came to see you out of network, and now I have a lymph node there. Do you think potentially the first operation could have been done better, so you got that lymph node? I said, yeah, probably could. And he said, well, would you be willing to do my operation for free? I said, yes, I am. So we did his second operation for free because we wanted to, he came, he paid a bundle price for a known outcome, and I was ethically bound to deliver that outcome. So I did it. Again, hospital very unhappy about some of these things. But I'm just like, look, I really just tell them to leave me alone for some of this, because for every one of these, I will bring you 500 more paying patients. Don't worry, and they know it's true. All right, so quality of care varies widely, and information on quality is absent. So I was having ice cream with my kids, and I'm like, one of my kids said, oh, Dad, I know you're a great doctor because I looked you up on doctors.com and you've got 5 stars. I'm like, oh, really? Look at those 2 cars over there. Do you think it's easier to figure out which one of those 2 cars is a better car, or to figure out which two doctors is a better doctor? It's much easier to figure out what's the better car, because we simply don't have that data on physicians. It's not out there. So we could measure this. We have the ability to measure it in 2016. We could report this. We could. I'm going to report this publicly to you right now. These are our quality data for thyroid cancer. I pulled this off of our electronic dashboards yesterday for this presentation. We have UCLA spun off a company called Ursa Health. And I'm able to look at every single thyroid operation we performed between April of 2013 and August of 2016. I'm able to show you how many of them were seen by an endocrinologist within UCLA at 6 months, how many needed to have additional surgery because we were only able to diagnose their problem after an initial lobectomy. Remember I told you that the lobectomy rate went down, so we were tracking that. How many of them had negative tumor markers within 9 to 18 months? 78.6 were biochemically disease-free at that rate. How many of them had radioactive iodine? You see this trend going down? We were over-treating people. We were giving people too much radiation. It used to be 100% at UCLA, but then the science moved. It turns out that radioactive iodine is only necessary in a small fraction of high-risk patients. We could use it less. And using that and behaving like a system, working with nuclear medicine, working with the endocrinologist, we got our rate of radioactive iodine administration from 100% down to about, if I were to narrow this bar and bring it down, it's about 25% now. Think of the overtreatment. We were guilty of overtreatment. And this is what I'm most proud of. What percentage of people are structurally disease-free at 1 year? 94%. 6% of people, we find some sort of regrowth or something. But that, to me, tells me, are we durably restoring people to health? And we can break this down by quarter, by semester, and we're constantly looking at what our outcomes are. And now you know our outcomes. There's nothing stopping us from putting this on the web tomorrow. I keep on telling the health system I want to do that. They're terrified. I cause a lot of trouble in the health system. But this is sort of a slide from Michael Porter. It's a terrific book, though a little bit dry, called Redefining Healthcare. Before I go into all 6 of these, I can't leave you without talking a little bit about hyperparathyroidism. And last year at this conference, I told you about, for those who weren't here, I told you about reducing fracture risk through parathyroidectomy. We published that work in June of this past year in the Annals of Internal Medicine, showing that among people who have primary hyperparathyroidism who undergo observation, if we have 1,000 people and follow them for 10 years, if you're untreated for the disease, 55 of those people will have a hip fracture. If you have a parathyroidectomy, the hip fracture rate drops to 20. If you have medical treatment with bisphosphonates, the risk of hip fracture was higher than observation. Not sure why, But that, we threw all sorts of advanced statistics on that. We could not find a single shred of evidence to say that bisphosphonates were helpful in lowering fracture risk in people with hyperparathyroidism. Seems to work in garden variety osteoporosis, but if your patient is hypercalcemic or if they have an inappropriate elevated PTH, watch out, you could be harming that person. But I mean, at least we can't say it helps, right? We're spending all this money on bisphosphonates and we have no evidence to show it helps in that group of people. Since then, we did a cost analysis. All I need to do is 10 parathyroidectomies. I will save somebody a fracture. That's a no-brainer. If that's a hip fracture, 20% of those people die within 2 years of a hip fracture. 60% of them never walk independently again. On average, it's a year of rehabilitation. And if I can do 10 parathyroidectomies, which our team can do in a day, prevent one fracture, yes, let's do it. That saves not only, so that in our cost analysis was what we call a dominant strategy. Anybody heard that term before in the cost literature? So if something's cost effective, it means it costs more, but it's worth it because of the quality adjusted life years you gain through that treatment. If something is dominant, it means it improves health and it simultaneously saves money, right? So, whoops, sorry, I think my mics just went off. But parathyroidectomy turned out to be the dominant strategy, right? So, oh, sorry, now 3 mics now. Okay, so just to wrap up, a little bit of Michael Porter for you from Harvard Business School. So he had 6 pieces of his agenda, and these were organized into integrated practice units. And what that means is we moved into an integrated center with our endocrinologists, and we see patients together every day. It makes things a lot more convenient for people. If they need a biopsy or anything, they just all can get it at the same time. Grow across geography. We're happy to do that. So every 2 weeks, we drive out. We have 4 surgeons now, and we run satellite clinics every 2 weeks, probably somewhere near your neighborhood in LA. So you have a choice. Ma'am, you've got a bad biopsy result today. Would you like to drive an hour and be seen in Westwood today? Or would you like to wait 3 days and we'll have a surgeon come to your neighborhood? Move to bundled prices. I showed you how we did that. Integrate care delivery across separate facilities. I showed you how we did that. Grew broadly across the enterprise. Grow excellent services. So all these things on top of an enabling IT platform, and I've shown you our analytics. So it's possible to do all of these things. And it's maybe most remarkably, it's possible to do them within sort of a bureaucratically difficult place like UCLA, you know. But you just have to be willing to shake it up a little bit. And part of all this is it took time to earn people's trust, earn enough trust within UCLA so people would actually buy into these crazy ideas. So that's all I have for today, and I hope you enjoyed it, and I just hope that maybe some of these little lessons we've learned, endocrine surgery is a small slice of healthcare, but it maybe in some ways is symbolic of what we can do in other respects to improve patient value, because I know that this crowd is all about patient value. So thank you so much. Okay, so Gary's question is about the active surveillance of thyroid cancer. He mentioned that he's had a bad experience with somebody who had a prostate cancer that was watchful waiting was chosen, and then the patient had widely metastatic disease. So when can you observe a thyroid cancer? That's really much an evolution. It's extremely nuanced. So I'm just going to go into one paper. Most of this literature is out of Japan, where they have an aging, advanced, the mean age in Japan is higher than any other developed nation, right? So they have old people with small thyroid tumors. And they have specific criteria. So it cannot be abutting the airway. It cannot be abutting the surface of the thyroid lobe. It sort of has to be right in the middle of the thyroid lobe. It has to be below a certain size. It can't be multifocal. There can't be any bad nodes. So right now, we're very, very picky as to which ones are eligible for active surveillance. And so far, the Japanese data with 5-year follow-up shows that it works better if people are older. For some reason, those tumors seem to grow more slowly. And if the patient is under 40, more of those showed progression and crossed over to surgery. And I'll just let you, because I just came from the thyroid meeting, they're doing an active surveillance protocol also at MD Anderson right now for these small things. And there's probably a small protocol in Los Angeles as well. So to answer your question, selection. right? You got to risk stratify every thyroid tumor, and I've told you about the criteria, which are fairly nuanced. I mean, you've got to do a lot of ultrasounds in order to say, check off those, but not on the airway, right? Not spiculated, not indenting the surface of the thyroid. So you've got to be very picky, because we don't want that. We don't want the undertreatment problem either, right? We're terrified of undertreatment. So where's that middle road where we're neither undertreating nor overtreating? Great question, Gary.
Thank you. So,
yeah.
Size of the thyroid nodule and whether it's
That matters too.
solitary nodule versus multiple nodules are
Also important, yeah.
Can you just sort of review your criteria for biopsying a nodule?
Yeah, so if it's less than a centimeter, we usually do not biopsy. That's easy to, if there's one thing to remember, that's one. If it's less than a centimeter, you usually don't biopsy. There are some exceptions. There are 1 centimeter, I saw a guy with a 1 centimeter tumor with metastases. So you really have to look at the whole neck. But if it's and then I'll reference an article for you. There are certain benign features on ultrasound. If it looks spongy, if it's purely cystic, there are some that are, but it's sometimes it deals with more subtle sonographic abnormalities. So if it's below a centimeter, leave it alone 99% of the time. If it's above a centimeter, start thinking. Start thinking about these more refined features. It's not just a thyroid nodule. Ask your sonographer, tell me about the features. Are there microcalcifications? Is there a blurry margin or a clear margin? Right? All these things. A little more nuance. It's harder. It's cognitively harder than to just say, just biopsy the thing, right? And that's what, I don't know if any of you read Thinking Fast and Slow by Kahneman, a really terrific book, changed my life, published in 2013, about how we make decisions. And he talks about cognitive ease. Like, we want to do what doesn't require that much thinking, you know? And so the answers I have for you are more thinking, which can be tiring, but helps the patient.
So
Yes, yeah, sorry, Tom.
why were the Koreans biopsying these 2-millimeter nodules?
Yeah, that's a great question. Why were the Koreans going so far nuts? It was a perfect storm of incentives. If you get cancer in Korea, whatever expenses you have are covered by the government. They have a national cancer insurance. So what was happening is then, of course, the doctors would want to overtreat because they're going to get paid. They're guaranteed to get paid. And then, this is like a nightmare, but an entire surgical industry blossomed up on the coattails of this tsunami of unnecessarily diagnosed thyroid nodules. People were using robotic, so sometimes people say, I'm going to fight a Korea and get a robotic thyroid operation. Why? Because in Korea, if you use the robot, you can bill a premium on top of that. And the fact that the government paid for it created a subsidy for that, right? Very much like the corn subsidy in this country, right? You subsidize corn, you get a lot of corn. Subsidize cancer surgery, you get a lot of cancer surgery, even if it's unnecessary. So this huge industry of like robotic surgery for papillary thyroid microcarcinoma blossomed up in Korea. And when I once was at a meeting and I said the same question, what is the deal? There was a Korean endocrinologist, I was like, what is the deal with all these thyroid operations? And he said, it's big business. That was his just nightmarish answer to that question. So there were economic incentives. The communication really streamlines and improves the care. We really try. Our EPIC, our electronic health record, we're supposed to be able to enter everybody's information. I hope we have yours correctly. But anytime we have a note or a path report and an imaging result, it should just pop out your fax machine, ideally. By the look on your face, that's probably not happening. It's not perfect. But whenever there's anything like that, yeah, by all means, call us, email us, and what we try to do is we try to make our service as good as yours. It's hard to do, but all of the referring docs have my cell phone. If somebody calls the staff and it's a physician, we instruct our staff, give them the cell phone. If the phone rings one too many times and it goes to voicemail, we have no voicemail bin. We just have a recording that's my voice and says, email me here. My email address. So if that phone is not getting picked up, I know immediately. And so it should always be picked up.